Thank you. So I do have disclosures, not particularly relevant to this talk, but there they are. I wanted to start out with some definitions and just clarify innovation from implementation. Innovation is the development of a technique, tool, or approach. There's a fair amount of guidance out there with regard to how this should be handled, but there's far less information out there with regard to how we should handle implementation, which is the incorporation of an innovation into general practice. And that's what I'm going to focus on today. And then just also to define informed consent, which is considered permission granted in the full knowledge of possible risks and benefits. And so there are ethical principles which underlie informed consent, primarily beneficence, which is the idea that a physician has an obligation to promote the welfare of a patient, and then respect for autonomy, which is, at least in the United States, the belief that persons should be free to choose and act without controlling constraints imposed by others. There is also the principle of justice, which applies more to innovation, and that talks about how there must be a just distribution of the burden of potential risk across the society. So why is informed consent important? Well, it enables patients to make medical decisions that reflect their own values and desires. It enhances patient autonomy. It allows for better patient decision-making and thus can improve the quality of surgical care. And it promotes a culture of openness and accountability. And it's known that poor physician-patient communication is associated with worse clinical outcomes. And so this is important by promoting the physician-patient trust relationship, which is really inherent to care of a patient and a prerequisite for cooperation. There are also legal theories that underlie informed consent, and primarily that's battery and negligence. Battery is the intentional touching of a person in a harmful or offensive manner, and in a surgical application that refers to a medical procedure performed without consent or beyond the scope of consent. Important thing about battery is even if the intent was good and the procedure was done well, a person can still be guilty of battery if there was no consent. In contrast, negligence is the failure to behave with a level of care that somebody of ordinary preference would behave, and so in similar circumstances. The difference for negligence is that the breach of duty on the part of the physician also has to be associated with some sort of harm. And so why do I bring up the legal issues? Well, in the United States, litigation involving novel surgical techniques has revolved around patients not being informed that the technique was experimental or carried risk. And so surgeons put themselves at risk of litigation if they fail to disclose that a proposed procedure is innovative, that the surgeon may not be entirely sure of outcomes, and or that the surgeon is on their learning curve. But do patients really want to know? Well, when we look at data on the published mortality rates after procedures, not a ton of patients actually access that data, and few of them change their decision about which surgeon to go to once they have seen that data. At the same time, Medicare patients report that the most important factor in choosing a surgeon is their surgeon's reputation. And so in many ways, patients may value this information even if it doesn't actually cause them to change the surgeon that they're going to. In the same way that patients want to know risks of procedures, even if they aren't necessarily going to stop the patient from having the procedure done. I do not have time, because I'm going to cut this shorter, to go into the history of informed consent. But just some highlights. In 1914 was the first requirement for physicians in the United States to obtain consent for patients. Prior to that, you did not need consent for a surgical procedure. In 1957, there was a more specific requirement that consent must be informed. It can't just be an agreement of, yes, I'll have a colectomy. It had to be a description of the risks and benefits of that procedure. And then moving forward, in the 70s, there was sort of an explosion of malpractice lawsuits. And so in the mid-70s, 25 states enacted informed consent laws, which were meant to put specifically in writing what was required in informed consent. I'll highlight this 1980 case of Truman versus Thomas. This was a case where a patient had repeatedly refused a pap smear and then died of cervical cancer, and the family sued the physician, saying the patient didn't know the risks of not having a pap smear. And so as part of this, the decision was that a physician is required to tell the patient the risks of not having the procedure. But I think actually more important that came out of this case is the second thing here, which says that if a physician knows or should know that the patient's unique concern or lack of familiarity with medical procedures, that this may expand the scope of required disclosure, which translates to even if your patient is of low medical literacy, you are required to explain to them in a way that they understand what the risks and benefits of the procedure are. And so we have 3 models of care in the United States, or have had 3 models of care. The first is the paternalistic model, which is sort of the doctor's knows best model, the idea that the physician knows what's best for the patient and you'll decide and do so out of their best interest. In the 20th century, we really moved more to an informative model, which is where the idea of just give the patients all the information we have and let them decide what to do. More recently, there's been a shift to shared decision-making, which is an in-between sense. One of the concerns about the informative model was that patients aren't going to know what to do with all this information. There's probably truth in that. And so shared decision-making is a physician helping a patient make a decision in light of the patient's priorities, goals, beliefs, and desired health state. So there are standards of informed consent which go along with these practice models. The professional practice standard is that of the paternalistic model. This was the original standard of informed consent, that what is it? Informed consent, you were expected to deliver the information that a reasonable physician would deliver. That evolved into the reasonable person standard, which means that you're expected to deliver the information of what a reasonable patient would want. And the last is the subjective standard, which is more of the tailored approach. Currently in the United States, there are laws in all 50 states. Most of them are in line with this reasonable person standard. The basics of informed consent: you need a competent patient that's adequately informed and not coerced. On the physician's part, you have to disclose the diagnosis, the procedure with risks and benefits, the alternatives, and the expected postoperative course. However, determining what is relevant information and how specific to be is really open to interpretation. And so this gets to the question of, if I'm doing something that I've never done before or I've only done a few times, how do I address that, or do I need to address that in informed consent? Required information is information that must be discussed. Protected private information is information about the physician that is up to them at their own discretion to discuss, but is never required. And optional information is that which you may not deliver all the time, but if a patient requests that information, you're sort of obliged to give them that information. So most experts agree that surgeon experience should be included in informed consent as either required or optional information. And there's both legal precedent for this and expert opinion supporting that. The 2 legal cases in 1996, there was a case, and without getting into the details, basically it was a ruling that surgeons' experience and risk statistics did fall under the purview of informed consent. Now, this case was subsequently reversed when they could not prove that the physician didn't provide that data, but the sentiment of the ruling still stood. In contrast, in 2001, there was a case with sort of an opposite ruling that said that personal information about the physician, including the physician's experience, is outside the scope of the legal doctrine of informed consent. So in this case, they ruled in favor of the physician and said they weren't required to provide that information. However, they did go on to say that the physician may have been guilty of negligence or misrepresentation, even though they did not actually violate informed consent. So, adequate informed consent includes disclosure of reasonably foreseeable risks of operation. In this case, individual surgeon skill is a component of foreseeable risk, particularly when a surgeon's on their learning curve. And I want to draw your attention to the Society of University Surgeons position statement on responsible development and application of surgical interventions. This came out in 2007, but there's really an overwhelming lack of familiarity with the document, but it includes a lot of good information, much like it was what is going to be covered in this session through all the talks. Specifically for informed consent, this statement says that a surgeon is obligated to tell the patient how the procedure is innovated, how it varies from standard practice, what is their own personal experience, what is known and isn't known about potential risks and benefits, both short and long-term, and costs, and what are the alternatives. And so I just mentioned cost here and want to stop there for a second because I think that this is something very few surgeons actually address with patients because we don't know how to address it. But the reality is if you are going to do something for example, robotically that you previously had done open, there will certainly be a difference in cost to the patient at the end of the day, but you may not be able to predict that and what that cost would be. It may be higher, it may be lower. It might be higher from more OR time, or it might be lower from a shorter length of stay. And so it's just important to acknowledge that there may be a difference in costs, and you may not be able to predict that for the patient. And so my practical points, you want to be honest with your patient. That's first and foremost, and will keep you out of trouble in this regard. And you also need to be honest with yourself. If you're having a hard time being honest with your patient because you think nobody's going to consent, because they don't think that you're ready to do this procedure, well then maybe you're not ready to do this procedure, and really being honest about whether or not you've prepared effectively for the case. Explain which parts of the procedure are new to you. Again, if you've done, dated example, but if you've done laparoscopic cholecystectomy and you've done open colectomy and now you're going to try a laparoscopic colectomy, it's important to let the patient know that you have experience with components of the procedure, even though the combined is new to you. Don't use excitement to coerce patients. It's really easy to say, oh, we've got this great new robot and this is so exciting, but you're not trying to coerce the patient. You're trying to inform them and make a decision that's in their best interest. Provide the data. This requires you to know the data. What are the outcomes of the procedure? And share that with the patient. And explain what is known and what isn't. If the short-term outcomes are known, but the long-term aren't because it's an innovative procedure and we don't know the 10-year outcomes, it's important to be clear about that. And then explain that your treatment results may not be as favorable as those described in the literature. If you've only done this once, it's really unrealistic to say that your outcomes are going to be the same as the expert who's published 500 case series in the literature. And then explain the steps you will use to keep the patient safe. Are you going to have a proctor? Is there availability of backup? Did you set out preset criteria for converting to a traditional procedure or aborting the procedure? And be prepared for your patient to elect not to consent. I think that we need to understand that some patients are going to choose not to participate in being our first case, and we can't feel that pressure that, oh, I have to get every patient to consent. When the right patient comes at the right time, then that's the time to do the procedure. So why would a patient consent? Well, they're going to consent for all the same reasons that you think the procedure is worth implementing, and those are important to communicate to the patient. Why do I think I need to change to this innovative approach? And what are the potential benefits that you see? Patients trust our opinions, and many patients want to be on the cutting edge of care and are going to be excited to be involved. And so in summary, informed consent is imperative when implementing a new technique or technology into your practice. Most experts agree that the information about your experience and outcomes is, if available, is relevant to informed consent. And at the end of the day, if this is something that you would want to know when deciding if you or your loved one should consent for a procedure, then your patient is most likely going to want to know that information as well. Thank you.